There we go.
Okay, how's that?
Perfect.
Okay, good.
Can you see my pointer?
Yes.
Yes.
Welcome everyone. It's really great, and I'm very excited to start this course. Really, the purpose of tonight's exercise really is to get you guys excited about the course. And I think the most important thing is that I want to show you how to prepare for this course, because there's a little bit of homework that you're going to have to do to get the maximum benefit from this. And we're going to get to that. It's very straightforward and simple. But I think it is going to make a massive difference to whether you are going to be able to implement this into your practice or not. So it's very, very important that we come prepared. So,
Stefan, sorry, Stefan, can you move a little bit closer to your mic? It's not that clear.
okay, how's that?
That's
Is that
good.
better, everyone? Yeah.
Yes.
Okay, cool. So yeah, I'm going to give you guys a taster of what this course is going to be. The first thing I want to mention, you can see there's the alternative date that it might be. First thing I'd like to stress is that this is really going to be a two-part course. Unfortunately, there's no way of getting around the fact that when you do the treatment from course 1, which is like very early interceptive treatment, you are going to have to finish the cases with straight wire at the end. So handled in course 2, which will be part 2. We will do that later on. I've been working hard. I've nearly got course 2 ready, for presentation, but it is a two-part course. And in this course 1, we're going to handle the early treatment that we're going to do to get our patients prepared and get them ready for finally finishing the cases with a straight wire. So that's course 1, the early interceptive orthopedic and orthodontic treatment. And course 2 is going to be finishing the cases with a straight wire technique. Now in course 1, the things we're going to be looking at is, first of all, we're going to look at a little bit of the background, the anatomy, how the jaws develop, just so that you've got a basic understanding on what we're dealing with here. Because as you will see in the course, that the bone of the maxilla is functional bone, and that functional bone is shaped by your tongue, by your airway, with your breathing, with your cheeks. So we are actually able to shape the bone of your face and make a massive difference in how you're going to look one day. Now, so we're going to do the anatomy and the biology behind it. As you can see here, we're going to show you sort of when is the right time to intervene and when the jaws grow at their fastest and when do they more or less stop growing. We're going to look at the background of that. Then we're going to look at how to identify patients that need this treatment or that can benefit from this treatment. We're going to look at the records that you need to take to be able to start this. And then we're going to help you analyze the treatment, which are the study models that we're going to look at. Show you how to look at the cephalometric tracing. It's not as daunting as what it seems, and you are going to have a lot of help with this. Triple O is fantastic in guiding you through step by step. So once we've helped you analyze your cases, we're going to show you how to fit the appliances. We're going to show you how to adjust the appliances. It is very, very straightforward, most of these treatments. The skill level involved with adjusting the braces is about the same as doing a composite filling. So it's not technically difficult to do with your hands. It's not like you're doing a sinus graft or a difficult wisdom tooth extraction. So it is something that I feel every single person who comes to this course will be able to do. It is definitely not something that's technically out of the reach for people. It's something we all should be able to do. A little bit of background about myself, to give you an idea where I've come from. I qualified in 1996 in South Africa, and I never worked in South Africa. I came to London in 96. I worked in a mixed practice there and then in a private practice. And I specialized in prosthodontics. I did a 5-year master's degree at King's. then I learned, I went into Astra implants, and I became a trainer for Astratech implants. And I also did quite a lot of the Invisalign treatment. So I didn't really have an orthodontic background at all. So I literally knew nothing about orthodontics well into my career until I made a discovery, which I will show you in a minute. So basically, I had a orthodontic background. My practice is in Guernsey. I don't know if any one of you have been to Guernsey. It's a lovely small island. There's about 25 dentists here. That is our practice in St. Peter Port. You can see here in the background, you can just about see the sea over there. So if you stand on my roof there, you've got a sea view. This is our practice. We've got 3 surgeries. There's our staff. This is my associate, David. He's specializing in endodontics, so he doesn't do any orthodontics at this point in time. And there's our staff. So the question is, what got me to start doing what we're doing? Now, it all started in 2007 when I saw this girl, Alicia Alexander. She was 7 years old, and she came to my practice, and I could just see that there was very bad crowding in her mouth. And you know, we did the normal fillings and sealants and stuff, but I just thought that something has got to be done for this girl. I then referred her to 3 different orthodontists. There was 2 consultants that used to visit the island, and I sent it to each one of those, and I sent it to the local orthodontist, and none of them said that we need to do anything. So 3 years later, I did another OPG, and she was 10 years old, and you can see what we could see there. Now, looking at that, my common sense said to me, something has got to be done about this. And I just could not find anyone to do something for this girl. Anyway, then I found out about Dr. Truitt. You can see all those teeth impacting there, no space, canine impacted. I found out about Dr. Skip Truitt's courses, and I did his courses, his 6 different courses. I did each one of them 6 times. So I became good friends with Skip as well, and most of the things that I've learned from him, and I'm really grateful for what he's taught me.
Sorry, Stefan, can I just interject just for 1 second? Guys, there's about 2 or 3 of you that have your mics still on. Can you mute your mics, because we're getting feedback? So I think Suzanne, Jenny, can you switch your mics off, please? Can you mute yourself?
Okay, got it.
Yep. Jenny, do you want to do that? Brilliant. And Stefan, do you want to come a little bit closer to the mic as well? Thanks.
Okay.
That's better. Thank you.
Okay, so I did Skip's courses back in 2011, and I carried on for the next 6 years, doing courses of 1 or 2 a year. I started doing the treatment, and then Alicia returned back to my surgery in 2013. So this is when I started doing this treatment, and this is what I found. When she returned, she came back for 1 holiday while she was in boarding school, and this is what we saw. Now you can see what was the end result of not doing anything for this girl from a young age. She ended up with a canine horizontally impacted underneath all her premolars. The orthodontist that was doing this treatment in London gave up on putting this tooth up, so he's just left it there. You can see there's the little gold chain that they've given up on. They've extracted 2 premolars in the upper jaw, and God knows what they were thinking with this bracket placements and everything. But anyway, so this is how she came back. And this is really what made me get into this. I thought I could see that this patient could have benefited from treatment. And you'll see a little bit later on in tonight's presentation what we've done, to try and get things back on track for her later on. But she's the reason why I started doing this. Now, I want to show you, and I'm pretty sure that most of you are seeing cases like what I'm going to show you now every single day in our practice. Patients like this come in, you can just see there's overcrowding, and you can see this patient is in the mixed dentition stage. You can see there's some ears there that's about to exfoliate, some teeth erupting, overcrowding everywhere. There's narrow jaws, there's a deep bite. You can see how narrow her face is there, quite a gummy smile. You take an X-ray, you see the teeth are impacting. Now, when you see this, you can either think to yourself, what can I do to improve this situation today? Or you can think, well, I'm going to leave this, wait for all the deciduous teeth to fall out, and then we'll see what we can do with what is left. So that is the choice that all of us have. Are you going to do something for this girl, or are you just going to leave it and refer it to the orthodontist or deal with whatever you have? Now, one thing that you will see when you start doing this treatment is that nothing magically is going to happen to this girl that's going to fix this. If you have an imbalance at the age of 7, 8, 9, or 10, I can guarantee you that that same imbalance you have is going to be there when that patient is 13, 14, 15, 16, and so on. So this is not going to treat itself. You need to intervene in this case to make a difference for her. This is another thing that is very, very common. It's anterior open bites. Now you can see that these patients are biting on their back teeth, and there's a big gap between their front teeth. Now, normally our teeth erupt until they find something that stops them from erupting, and in this case, it's the tongue. Often it's the thumb. Patients suck their thumbs. It gives you an open bite, and then it is replaced by the tongue. An open bite in an adult is a total nightmare to treat, because the patient learns that habit of swallowing with their tongue going into that space. So this is one of the things that you have to treat as soon as you see it. Now, the thing with nature is nature is very, very consistent. It does the same thing every single time. So you can see a lot of these slides that I'm going to show you is a young patient with a problem, and that problem stays with you right through your life, unless you intervene. These patients have all got developing skeletal class 3s. Now, skeletal class 3 is when your mandible is overtaking your upper jaw. Each one of these 3 patients has been seen by the orthodontist, been taken there by the parents because they're concerned about their children, and every time the orthodontist said, listen, you are going to need jaw surgery when you're older, so we're going to do nothing for you now. Come and see me once you've lost all your baby teeth. And that is the worst possible thing, because if these cases are picked up early on, you can make a massive difference to these patients. A majority of the cases, you can actually avoid having the surgery. These patients have got the opposite problem. They've got a lower jaw that is stuck back, a skeletal class 2. Now, a skeletal class 2 means that the lower jaw cannot come and grow forward into a comfortable class 1 position where it wants to be. There's something stopping this mandible growing forward. Again, if you've left this class 2 to be where it is, it's going to stay there for the rest of this patient's life. By the time that the patient has stopped growing and reached puberty, for instance, this girl, if you leave this case until she's 14 or 15, she's going to look like this for the rest of her life. Now, you can make a massive difference to these patients, and I will show you the results later on in the thing. Another thing that's a very common problem we see is arch length loss, when the back teeth drift forward in your mouth and they start to impact the new teeth that's trying to come through. Normally, the teeth that gets impacted are the canines, because your canines are normally the last ones to find their way into your mouth. And if there's not room, they are the ones that get stuck. Again, this is something that the sooner you treat it, the better. The question is now, what does our colleagues do? What does the orthodontist do with these cases that I've just showed you? Here is an example. This 8-year-old girl came to see me, and this is quite early on when I was doing this treatment, about a year or so into when I started doing this. She came in, and what you can see here is you can see how narrow her upper jaw is. You see how her teeth are shaping up. You can see that her whole face is bent. This lower jaw is shifted to her left-hand side. There's the lower midline, there's the upper midline. So you can see her whole lower jaw is shifted to this side. The reason why that happens is because her upper jaw is too narrow. This upper jaw didn't develop properly, and the lower jaw is bigger than the upper jaw. So the only way that she can make her teeth fit is by shifting her lower jaw to the side. So that's where she is. You can see there, and this is called a bilateral skeletal crossbite with the mandible deviating to the right-hand side. You can see that our whole face is distorted. Now, if you leave this, she will stay like this for the rest of her life. We did the case analysis. We did the assessment. We found out where her lower jaw was. You can see her upper jaw was stuck. Do not worry about this. We're going to go into detail in how to analyze these cells. This pulmonary lead tracing that we do is the fundamental information that we use to determine where the skeletal relationship of these patients are. It tells us where's the upper jaw in relation to your anterior cranial base, which is the skull, and it shows us where your lower jaw is in relation to your skull. So it shows us the balance of the face. It also shows us the female aesthetics. It shows us the lip support, and in girls it's very important to have enough lip support. We did a detailed analysis of the case. You can see here we found out that our upper jaw was 9.5 millimeters too narrow. And I want to add that this is all things that Triple O do for you. So you don't have to measure the models yourself. I'll show you how to do it. But this comes back. All you need to do is you just read it off the work that comes back from the lab. And we've got those comments here. Line compliance that's recommended for the treatment. So it's all done for you. You can see here on this OPG how these canines were impacting because of that upper jaw that's too narrow. See? So what I did is I fitted this appliance. This is a Schwartz appliance that's going to expand that upper jaw and make the upper jaw wider. And we were going to use a reversible headgear to bring that upper jaw forward, as we saw that we needed to do on the Wimler analysis. In addition, this poor girl had an attached frenum. You can see the frenum there, and she had a tongue tie. You see her tongue is stuck to the bottom of her mouth. Now, that tongue tie is the reason why her upper jaw didn't develop properly, because whenever she swallowed, her tongue couldn't press in her palate. So her upper jaw was too narrow. And remember we said that the bone of your face is shaped by muscle and air pressure. Anyway, so I explained all of this to the parents and to the patient, and I said to the girl or to the parents that she's going to need to have these frenums surgically corrected. We do that here with a laser at our surgery. Anyway, so the parents then panicked. They were concerned. They obviously was worried about their daughter having oral surgery, so they went for a second opinion. A week later, I got this letter back from the parents. So they went to a practice down the road. There were two dentists there. Both of them are in their late 50s. They're very experienced dentists, and they had a visiting orthodontist there. That orthodontist looked at that expander that I fitted for that girl. After all the explanation and all the information we showed him on black and white, that orthodontist looked at this patient and said she was shocked that we said she was tongue-tied. She doesn't need a frenectomy. Her teeth were not overcrowded. The palatal expander will not promote bone growth. It will create more problems by pushing her teeth outwards. They said she would. So they asked the specialist, what would they do if it was her daughter? And she said she will not put the expander back. She'll just leave it exactly as it is. And then they explained about, because obviously I explained about the jaw, the deviating mandible, the narrow maxilla, everything. And they said there's nothing that concerned the orthodontist about her jaw being out of alignment. And she said it's simply not the case. Again, she stated there was no overcrowding. And then asked what would that practice do? They said they will wait until all the adult teeth come through, along with careful monitoring, meaning doing nothing. And they will be able to choose the best course of action for Caitlin, which is around 13 years of age, which normally means extracting teeth. So this is their opinion. Now, obviously, because there was 3 of them that told the patient this advice, they came back to me and said they want a refund. So I did give the girl her money, the parents the money back, and I never saw Caitlin again. So this happened 6 years ago. Fortunately, I don't get a lot of this because I normally want to really make sure that the parents understand exactly what is the problem and what's the treatment before they leave here. But I showed you this case just to show you what you are going to be dealing with when you start doing this treatment. There are going to be dentists and orthodontists that looks at these cases and say, listen, don't do anything, it's fine. So you need to be prepared for that because it does happen.
Stefan, sorry, can I just come in again? We're still getting some feedback. Arthi Shah, can you mute your mic, please? And Jenny, can you please mute your mic?
Bijou, I couldn't hear a word when I moved my mic though, and I've got nobody in the room and I've got nothing going on. I don't mind if I need to, but I can't hear.
I'm getting echo from your room, unfortunately. I'm getting feedback.
Okay, so, but I can't. Okay, shall I go?
No, I don't know. I'll leave it to you.
I don't mind. I'll try. Let me try that.
Can you listen with headphones?
That's better.
Yeah.
Can you hear? Okay. Now, that girl we've just looked at with that deviating mandible to the side, the bilateral skeletal crossbite, she was 10, 11 years old when we took those pictures. Now, she would have stayed like that if nothing was done. This patient I'm showing here is 29 years old with exactly the same problem. Can you see there's a lower midline, there's the upper midline, her lower jaw is shifted to the left. You see how her whole face is bent. So this shows you that if you don't intervene with that problem, this jaw stays there. Now, she came to see me because she was referred to me by her psychotherapist, being concerned about her because this girl was suicidal from chronic face pain. She had chronic pain on the left side of the face in front of her ear, so much so that she actually wanted to take her own life because she could not cope with it anymore. Now, what happened here was that lower jaw is shifted to the left, which meant that the condyle on the left has gone back and the disc has popped forward and she's got a dislocation in that jaw. It's caused all this pain and problems. Now, all this, you see there how that jaw shifted and deviated to the side, causing the TMJ problem. All that could have been prevented by having a simple appliance like that. This is the same appliance that we fitted for that Caitlin that they took away from her. Look at this girl. We picked her up at the age of 4 or 5. We fitted that Sagit. This is a Schwarz appliance, a 2-screw Schwarz appliance with occlusal coverage. She wore this for about 4 months by gently turning these screws. Now we're going to show you it's very straightforward and easy to do. And what this has done is it developed this upper jaw transversely. And look what happened. That upper jaw now is wide enough so that her lower jaw can fit in the middle. And that lower jaw returned to the middle of her face automatically. So we didn't even have to reposition her jaw. It naturally went back in the right place because we corrected the imbalance between the size of the maxilla and the size of the mandible. Now, all that problems could have been prevented with this one appliance. And this really is the definition of early intervention. You need to pick these problems up, you need to have the insight, and you need to have the knowledge to know which of these cases you need to see early on. And I'm going to show you each and every one of these. This is about 3 years later. You can see that she's done quite a bit of growing now. Again, her lower jaw is in the middle of her head. It's perfectly lined up. Midlines are fine. But we found that she was a little bit narrow in this pre-maxilla area. So we just developed that a little bit here with a fan type Schwarz appliance. Again, I will show you how to do that. Now I ask you, if I go back, where would you rather want your own daughter to be? Do you want it to be here and leave that and ignore it? Or do you want it to be there? This is a case that I saw 2 weeks ago, just a week before they closed us down with the virus. This boy came to see me. His mother was desperate to have treatment. She used to go to another dentist. She asked the other dentist to refer her to our local orthodontist. She ended up at the orthodontist. The orthodontist looked at this boy and he said to the mother, there's nothing wrong with his teeth. Look what we've got. Exactly the same problem. Look at that. Now the problem is, remember we were saying that your jaw gets shaped by function. This maxilla is stuck here now. and it's making the problem worse. This cannot grow wider because it's in crossbite here. And you've gone off the disc, TMJ problems, all sorts of issues. The following day, I saw this boy. Look, see where that mandible is? Now, he ended up going to the children's dental service at our hospital. There's a children's dental section, and they've got a visiting orthodontist there who comes from the UK. He looked at this case, and his treatment plan was to extract all 4 of the 6s because this tooth had mottled enamel, and they saw that there was a canine impacting up here. So they thought it's a good idea to leave the skeletal problem exactly how it is and pull out the 6s. He was booked in. He had a theatre appointment to have all 4 6s out in one go. He was put in his gown. While they were prepping the theatre to pull him in, his mother decided she's going to stop the whole thing because she just felt that it wasn't the right thing to do. They cancelled the operation. They came to see me. They found out through friends of theirs about our practice. And thank God, because I cannot for the life of me see why those 6s needed to be extracted. And this is a perfect case. All this patient needs is a simple Schwartz appliance developed at Maxilla. There'll be room for the teeth, the mandible will be in the right place, and the patient will end up with all his teeth in his mouth. That's the teeth that we're going to extract. There's the impaction of the canine. Here's another one. Look at this. This patient's a little bit older. You can see there's the canine impacted, narrow arches. It's obvious. You can see this, the crowding she's got. There's a canine impacted down there. She's still in the mixed dentition. She's got an E there. You can see how the lower dental midline is shifted. You can see her midline's here, and the skeletal midline is there, and the dental midline's over there. So the midline is shifted. Look at the X-ray, impacted canines everywhere. This case is definitely going to look at extractions if she goes anywhere else. So the specialist at the dental clinic recommended they sent the patient to me to pull the teeth out. So obviously when I got this letter, I said to the parents I refused to do that because the thing is they get the treatment for free at the school clinic. And obviously they have to pay privately when they come to me. I explained to them, so there was quite a bit of a fight with this one because they went back to the school clinic and said that they wanted the specialist there to do what I was going to do for her on the States. And the States didn't agree with what I was going to do, so the parents ended up coming back to me and they found the money. Grandmother decided to pay for the treatment and we ended up doing the treatment for her. I will show you in a minute where that case went. So this is what normally would have happened. They take out the force. Now what's happened here, and this is very, very important because believe me, this happens every single day. These patients end up with a lower jaw back. Can you see that this chin is back? That's a skeletal class 2. The chin's back. So when this patient bites down, it looks like the front teeth are sticking forward or they've got a big overjet, a dental overjet. So what the orthodontist will do, or people do, is they look at this and they say, well, we need to get the front teeth back to match the lower jaw where it's stuck back. So what they do is they extract the 2 premolars in the upper jaw and they pull the front teeth back. Now this patient came to see me at this stage because again, the parents, they moved from Canada to Guernsey and she came to see me and obviously, what do you do? So it's too late now. So what we are going to do for this boy is we're going to have to put implants back in because there's no way that I'm going to pull those front teeth back to meet these premolars. So what needs to happen here is we're going to need to develop this upper jaw and bring the lower jaw forward and then put the teeth together. But this is not the way to treat them. What is the result of when you take these teeth out? Look at this guy. He's like in his middle 30s. They extracted his upper fours. Look what that has done to his profile of his face. Your front teeth are supposed to be in line with your end point here and your chin. Your front teeth are supposed to be there. His front teeth are there. We call this a dental division 2, when the front teeth have been pulled back. And as those front teeth are pulled back, look what it's done to the bite. It's given him a deep overbite. Now that deep overbite traps the lower jaw back. Now that lower jaw that's trapped back is very uncomfortable, and these patients, men especially, they grind their teeth. So it's not uncommon to see patients that's had this work done grind their teeth when they get older. In women, instead of grinding their teeth, they end up with temporomandibular joint problems. Look at this guy. Look what they've done for him. Extracted his fours on the top, pulled the teeth back, same thing. Look where his teeth are. They're supposed to be here. They're like 10 millimeters back. It's trapped his lower jaw back, and he's managed to grind his way out of this entrapment. That's why his front teeth are so flat. Look at the destruction that he's done to his front teeth to try and get his lower jaw to be down and forward where it's comfortable. So, look at this guy. They decided to pull 4 teeth out in his maxilla, and they pulled out his lower incisors on the top. Look at where his front teeth is compared to where they're supposed to be. So everything gets pulled back. And it affects your profile and the health of your joints. This patient, tongue thrust, remember we looked at the tongue thrust earlier? They never bothered to check the tongue thrust. They didn't really understand the problem. So what they did is they extracted the force, never treated the tongue thrust. 6 months later, the patient had an open bite again because they never treated the tongue thrust problem. And now you can see how narrow her upper jaw is. Can you see how narrow? If you look there on the left picture, you can see that buccal corridors there. That maxilla is very, very narrow. It's changed the whole shape of your face. Now, I have cases where patients like this got crowding. They went back and had teeth taken out again. I've got a number of patients where their canines and their sixes are next to each other. Now, to undo this for a 50-year-old, it's 4 years of work to fix that. And this could have been fixed when she was 5 years old with a Schwarz appliance, a tongue wires, and a spinner. And she would have been right on track, wide maxilla, all the teeth in the mouth, tongue thrust fixed, no problem. See, there's the tongue thrust. So what does these cases have in common? The cases that had their fours extracted? Look, every single one has got the front teeth leaning back. Look, there's the premolars extracted, front teeth leaning back. Each and every single one of them. Look how narrow that jaw is. This patient had ortho. It's gone straight back again. And every one of those ladies came to see me, not because of cosmetic, because this is, the teeth looks fairly straight, as you can see there, but every single one of them came to see me because they had clicking joints, headaches, grinding in their joints, and all sorts of problems. Now, I think it's worth at this point saying that we are going to, Patrick Grossman is going to do a detailed course on the TMJ, so he's going to be handling the TMJ. The TMJ treatment ties in with everything that we're doing in course 1. So it's all linked together. The TMJ is fundamentally important for us. So it is very, very important that we do the TMJ course as well. Now, what we've seen so far is these patients had the overcrowding, they had the problems, and the dentist extracted their force, they pulled everything back. You've got another option. The other choice that you can make for these patients is what I'm going to show you right now. That same patient that was sent to us to have the force extracted by the school clinic, the parents just knew by themselves it's the wrong thing to do. So what we did for us, we did a proper analysis. You can see there how narrow that maxilla is. This is called the vertical smile index. Your premolars are supposed to be in line with the inside of the irises of your eyes. That shows you how wide your smile is supposed to be. You can see here from this line I drew there that her upper teeth were back, the lower jaw were back. We did the cephalometric, the Bimler analysis. This puts numbers to what we're going to do. I'm going to show you how to analyze all this. Triple O helps you with that. This is basic fundamental stuff, and there's no doubt that you will all get this down at the course. We're going to go into detail in analyzing that. Looking at the dental arches, we do a symmetry check to see the symmetry of the jaws. You can see how asymmetrical that jaw was. You can see how the upper midline is shifted and it trapped that canine in place. You can see the lower shift of the midline here, trapping that canine. Triple O helps us do this Schwartz-Korkhaus analysis. The Schwartz-Korkhaus analysis shows us how to what size we need to develop the arches so that there will be enough room for all the teeth. So we use these measurements as a guide to see how wide we need to develop these arches. So we can see here from the analysis that this upper jaw is 12.5 millimeters too narrow here. Now, obviously, you've got one of two options. You can leave this jaw this size and extract those premolars to get the canine in and end up with the patient having a narrow maxilla. Or you can develop this upper jaw and make room for the teeth. That's your basic choice. Unfortunately, this patient has been left a bit long, so this is a little bit more complicated. This should have been treated when she was 7 or 8. And then we wouldn't have had all these impactions. Anyway, so what we did is we fitted a RN sagittal appliance for her. Now, RN sagittal is the adult version of that Schwartz appliance that I showed you before. This RN sagittal, we are going to show you how it works, but mainly we're going to focus on the RN sagittal and the lower ELF in course 2. So that's why it's important to do course 2 as well. And you can see every single case we do needs to be finished with a straight wire technique. You just need to have to learn to do it. It's not that complicated. Again, I will show you step by step how to do it. But we use the RN sagittal, ELF to develop, to make the jaws wider according to those measurements that we've done before. And we've used this straight wire technique to level and align the teeth. And look at that difference. And you see how that maxilla has developed. Now, this has opened her airway. It's made the maxilla wider so she can breathe through her nose better. And look what it's done to the shape of her mouth and her face. Look at that. You see how the shape of that maxilla has changed. And she's got a full smile now. You can see there's no dark buccal corridors there. And her vertical smile axis is right on line. You see how it's changed the entire shape of her face and her profile. You see the profile is correct as well now. And this means that her mandible is in a comfortable down and forward position, so she's not going to get DM joint problems as well. That previous suggestion where they wanted to extract the fours and they were going to go straight into the fixed braces meant that they were going to leave the mandible exactly where it was and make her teeth fit in that position. So that is purely orthodontic treatment. What we are doing orthopedic treatment, which means we correct the skeletal imbalances before we do the orthodontic treatment, which means we put the teeth together. This is that Alicia. This is the case or the patient that made me take up this treatment. Remember, she came back from boarding schools having orthodontic treatment in the UK. You can see that's where she was. First thing we wanted to do is get all that brackets off. Took all the brackets off, and this is what we were left with. You can just see how sunken in that face is. Look. The analysis, never do treatment unless you've got the proper analysis, black and white. You want to see what everything is. You want to do your Korkhaus analysis. There's your measurements that you're going to work towards. That is an ELF appliance. You can see this is an ELF appliance. This ELF appliance develops the maxilla, and we had the straight wire on top. This is course 2 that we're going to show you how to do this. And this is the result that we ended up with in the end. This is a little bridge we made for her down here. We had to surgically extract that 3 that was lying underneath those teeth. So I'm not going to, by any stretch of the imagination, say that this case is perfect. But for what we had, I did my best. I mean, I developed the living daylights out of that maxilla. I tried to get it as big as I could get it. By the time we developed that, there were teeth missing already. So the point I'm trying to make is, do not let your cases get to this point. And what will bother me for the rest of my life is knowing that I saw this patient when she was 7 years old and I was unable to do something for her. I knew something had to be done. I sent it to 3 specialists to do something, and she came back like this. And unfortunately, I just cannot rewind the clock. Like I said, I did my best, and that's where I got it to. So there I'm saying it that ideally we want to prevent these cases to get to that point. That's why we need to identify and treat these cases before they become a major problem, and that is what course 1 is all about. Now, again, this is what I was mentioned before. We're going to look at the anatomy. The bones of your face is completely changeable. You can change it with the functional appliances that stimulate the bone growth. For your jaws to develop correctly and in balance, you need to swallow correctly, meaning not with a tongue thrust. It's a very, very common problem. And you need to breathe through your nose. Mouth breathers have all sorts of problems as well. We're going to look at the anatomy. I've got some videos for you, some animations to help you understand the anatomy. We're going to look at all the factors like thumb sucking, tongue thrusts. We're going to look at all those factors that influence the shape of the bone of your face. I'm going to show you the research. There's loads of research on thumb sucking, mouth breathing, all that. This is an article of a dentist showing off his case in the Journal of Clinical Orthodontics. And they wanted to show how magic TADs work in retracting the canines. Look what they've done here. Look where that mandible is. That lower jaw is stuck back in a skeletal class 2. Okay, they've extracted the teeth in the upper and they're pulling all these teeth back to match this lower jaw. So I want you to be able to look at cases like this and see what you would want to do differently. So don't just look at this as, oh, well, this is the way to do it. It's not. This is the TMJ. You can see here, that is a mandible that's strapped back with a dislocating disc. This is where you are supposed to be. And this is what Patrick Grossman is going to help us and show us the course on the TMJ treatment. Fundamental to what we are doing. Put this slide in because this is the kind of cases that you need to start looking for this as soon as we get back from the virus. You need to look at every child in your practice to see, and I can promise you, on the first day, you're going to see 3 or 4 of these patients. There's hardly a child that's 7, 8, 9, 10 years old that cannot benefit from treatment. If you're a little bit worried about, if you're feeling a little bit, if you haven't got a lot of confidence at this point in time, see if there's a family member. Treat your own children. See your friends' children. Just get that first patient booked in. And I was talking to Bijou about this last night. Whatever you are going to do for these patients are going to benefit them. It's impossible to cause harm with what we are doing. So you need to look at these cases. You see, we've got anterior open bites. An anterior open bite is something you need to treat as soon as you see it. If this patient is 3 years old, you treat it. And I'll show you in a minute the example of a case that was 3 years old that we treated. Arch length loss. That canine that's impacted there is never going to find a way into this mouth. The sooner you stop these teeth sliding forward, the better. You need to book them in and treat them immediately. A bilateral skeletal crossbite, when those midlines are not lining up, when the mandible is shifted to the side, easy fix. Schwartz appliance with occlusal coverage. a developing skeletal class 3. This patient here on the lower left-hand side, this patient is heading for surgery. You can fix this, you can develop this upper jaw as soon as that. If you pick this up at the age of 6 or 7, you've got a very good shot at preventing this child from having his jaw broken later on. Division 2 cases, look how that mandible is strapped. This needs to be treated as soon as you see it. A really good sign to pick up whether a patient is developing into a class 3 is when you see wear on the lower teeth, on the baby teeth. You see that wear there? You can just see that this patient's lower jaw is trying to overtake the upper jaw. That is immediately alarm bells ringing, knowing that we're going to end up there pretty soon. Now, we're going to show you this, or we're going to come back to this in a minute. This is the Bimler analysis. I'm going to show you how to analyze this. We're going to look at each one of these measurements. Please do not be daunted by this. It's very logical, and the Bimler Elite tracing that we use is by far the best way to analyze the balance of your face. It makes a lot of sense. It's very clear, very easy to do. This is that Schwartz-Korkhaus analysis that we talked about. There's a formula that we use. If you know what is the size of the 4 front teeth, you see there the upper incisal width. If you know how wide the front teeth are, you can use this formula to know how wide you need to make the jaws for them to fit all the teeth in. And that is how we do that. And we're going to show you how to measure it. There's other things that we're going to look at, like the position of the teeth. When do we have a lip sucking habit? When do we have an open bite? We're going to show you how to identify all those problems. Now, this is what you're going to get back from Triple O. And we're going to talk about this in a minute later as well. So you've got your treatment plan, you've got your Schwartz-Korkhaus analysis, you've got your study models, you've got your cephalometric analysis. We'll look at that in a minute. What I've spent quite a bit of time trying to get make a flow chart for us to use this flow chart to see where the treatment needs to go. And I've got 2 different flow charts that basically does the same thing. But this flow chart is going to help you identify. So you're going to look at the class of the mandible, and it's going to show you if a patient's a class 1, 2, or a 3. Then from there, you're going to look at the maxilla, and it's going to show you which appliance you can have. So you can go there and follow these arrows, and it will tell you exactly what appliance you need to use in the upper jaw, what appliance you need to use in the lower jaw, what appliance you're going to need to open or close the bite. So you'll be able to find your way in this roadmap. If you're a class 3, the treatment for all class 3 patients are the same. Now, again, I want to stress that nature is very, very consistent. It does the same thing every single time. And that is why, if you see a problem in a 7-year-old, you know exactly how that problem is going to end up when they're older. And that is why we can do this treatment. This is another example of that flow chart, which I've just done without the arrows. Again, from this flow chart, you'll be exactly able to see where you are. And then we're going to compare that with a suggested analysis from the lab. Triple O will help you design the appliance. You can got a whole host of colors that we can choose from. This is the exciting part for the kids. They can pick their colors. Then I'm going to show you how to fit these appliances and how to adjust them. Like I said before, it's as simple as putting a key in a lock and turning it. And I'm going to show you how to do the adjustments. You need to shape the acrylic a little bit. You're going to need to bend a wire here and there. But these appliances, they just work. And it's very, very simple and straightforward to fit them. A twin block is an appliance that repositions the mandible. Obviously, I'm going to show you some animations on how these appliances work. What I'm trying to show you here is, can you see, I'm going to try and rewind this twin block appliance, when this patient's lower jaw is stuck back. And as they bite on this ramp and they slide forward. That bite and slide forward is the way that we reposition the mandible. If you put an elastic band on the mandible and pull it forward, All you're doing is you're rotating the mandible and you're not translating. This is a Bionator appliance. This Bionator appliance is probably the best appliance that anyone can use. This Bionator you can only use that in the mixed dentition, so you still have to have some of your baby teeth. When you're in the permanent dentition, we use the twin block appliance to bring the lower jaw forward. Now, this Bionator is absolute magic. When you look at this Bionator, you think to yourself, well, no patient's ever going to want to wear that. Trust me, patients love a Bionator, because what a Bionator does is it puts your jaw in such a comfortable position you don't want to take the thing out. So I've never had a compliance problem with the Bionator. So what this Bionator does is once you've developed the arches, do that Schwarz-Korkhaus analysis we've done before to show you how big you need to make these arches, you wear this Bionator to hold your jaw forward to make the bone change so that your bone keeps your lower jaw in the right position, because we don't want to just posture it forward. And I'm going to show you how long they need to wear the appliance, how often they need to wear it, how do you adjust it, how do you check it. I want to show you everything. As a bonus with this Bionator appliance, with the Bionator, you can actually open the bite if a patient's got a deep bite, or you can close the bite if a patient has got an open bite. Or you can actually just keep the vertical where it is and just bring the lower jaw forward. So a Bionator does three things at the same time. It's a retainer for the previous arch development that you've done. It can translate the mandible forward in the correct skeletal position, and it can open and close your bite. A Bionator is magic. This is how you take the construction bite for Bionator. I'm going to go into great detail in showing you how to do it. It really is as simple as taking an impression and sending it to the lab. Remember, we looked at this anterior open bite. This boy was 3 years old when he came to see me, and he had this open bite with a tongue thrust. He used to suck his thumb, and he had that open bite. So what we did is we fitted him with this very simple Schwarz appliance. He used to have 2 little tongue wires in there, which I cut off after about 3 months. He had a little spinner up there to attract his tongue. The parents turned the screw and this brace grew. You can see how much that brace expanded. I then replaced it with a tongue gate. You can see that, to keep the tongue out of that gap. And look what happened to his teeth. Now, if you look at the left and you compare it to the right, can you see that that bite automatically closed because we got the tongue out of the space? And there's enough room now. And what we've done is we've put his development back on track. So now this patient is developing properly. He hasn't got a tongue thrust anymore, and we don't have to worry about an open bite. One thing that I have to say, remember we mentioned before that an open bite is something that gets significantly worse as you get older. To close a bite is very, very difficult, because when you bite on your back teeth and you've got your front teeth apart, it means that you literally have to drive your lower teeth into the bone to close that bite. It is very, very difficult. So that is why we need to treat these anterior open bites as soon as we see them. This is an example of a patient where we translated a mandible into a skeletal class 2. Can you see there on the left, you see how narrow that upper jaw is? Now, a narrow upper jaw is the #1 reason why the lower jaw gets strapped back. Can you see we developed the upper jaw? It's made a nice wide smile, filled out her smile. And then she wore a twin block and it positioned the lower jaw for the profile. The alternative is to leave this patient, extract the falls on the top, leave the mandible where it is and pull those front teeth back and lock that lower jaw into a trap back position. That's your 2 options. This patient was actually the 4th patient that I started treating with this. You can see there's like 8 years. So it was the very first week when I came back from course 1 is when I started treating this girl. And I'm telling you this because you will be able to do this from the Monday that you finish the course. She came in, you can see narrow upper jaw. We developed her jaw, made it nice and wide smile. We translated her. She had a bionator to bring her lower jaw forward. And look. I mean, she had a tongue thrust. She had that golf ball you see there. That's a typical sign of a tongue thrust. So we fixed the tongue thrust. We fixed the narrow maxilla. We translated the mandible. We put the teeth together. And that is the results that each and every one of you will be able to achieve. Here's another one. Mandible stuck back. You can see she's a mouth breather. You can just see the venous pooling under her eyes. You can see the way her mouth's hanging down. Mouth breather. So she had a narrow upper jaw, lower jaw stuck back. We developed the upper jaw, translated the mandible, corrected her profile. Another one. See how the mandible stuck back? Developed the upper jaw. She had a bionator as well, this patient. Look at this one. Narrow upper jaw. We developed that upper jaw. Can you see how it filled out her smile? Translated the lower jaw forward. She had a twin block. You see, we corrected that profile. This photo I took 3 years after we finished the braces to see what I'm doing now is I'm taking photos of years later to see how stable our results are. This is 3 years after she stopped wearing her retainers. Can you see how stable this result is? It stayed exactly where we want it. Actually, I think it looks even better. Now, this is not the same patient, obviously, but I want to show you what is the difference in the profile of your face. This is just aesthetics. What's the difference in the profile when you extract the force in the upper jaw or when you develop the upper jaw and translate that mandible? Look at the shape of this patient. And again, this girl was 18 when she came to see me. Agony, clicking joints, headaches, grinding when she opens and closes her mouth. And that's all because this lower jaw is rammed back and she's off the discs. You can see that this face is in balance, the mandible is down and forward, and she's got a comfortable PMJ. This is a boy, same thing. Narrow upper jaw, developed him, brought his jaw forward. Look at this patient, before and after. You can see there, that patient would definitely have had some teeth extracted. Not a single tooth extracted would line all that up. Older patients, this patient was 32 when I treated her. So there's the maxilla can be developed up to any age. I've got patients that's in their 60s that we develop these upper jaws. The one thing though that is a nightmare to treat later on is to translate the mandible. To bring the lower jaw forward into a skeletal class 1 is very, very difficult once you've gone through puberty. And that is why you have to treat these class 2s as soon as you see them. This patient had a narrow maxilla. You can see how narrow her upper jaw is. We developed her. You can see how it filled out her lips and gave her the wide smile, the vertical smile axis. So they're actually friends of ours. Her mum is good friends of my ex. And they asked me to take some photos of them, mother and daughter pictures. So I took these pictures of them and I noticed, can you see the difference? And the mom's actually a patient of mine as well. She had her upper force extracted when she was younger. Can you see the difference in the shapes of their mouths? She had a force out in the upper. You can see those buccal corridors on the sides. Narrow maxilla, front teeth, everything leaning back. Look, we developed the upper jaw and she's got a wide smile. I've made a few videos of case discussions that I did with the patients. I'm going to show you how to discuss the treatment plans with the parents and the kids. It's taken me about 9 years now to come up with a bit of chatter about this, and each one of you will have to learn your own little story that you tell. I can give you some, advice on what has worked for me. I try to keep things really simple, and I really make sure that the parents understand exactly what's going on. I'll go back to this. So I've got quite a few videos where I sort of show you firsthand how to bring the message across to your parents. We are going to have a short section on practice management. I'm going to show you how we charge for this. One thing is for sure, you need to charge properly for this treatment because it does take your time. The appliances cost you money. But one thing that I've seen over the years is that parents do not mind spending money on their children. They'd much rather sort their kids out than themselves. And we have a very, very high acceptance of treatment plans because we make sure that the parents understand the problem. And there's very, very few parents that look at these cases. They can see the teeth are impacting on the x-ray. They see that the mandible is strapped on the pulmonary lid. It's black and white. When they see that, what parent are going to look at that problem and say to you, I don't want to fix it? Now, while I was putting this course together, obviously I did quite a bit of looking around on the internet, and you are going to be shocked to see on YouTube what the young people nowadays are doing to try and treat themselves. There are loads of videos of patients saying that they refuse to have their teeth out. They've heard about John Mew. If you put in mewing on the internet, you will see these people have got millions of views. These guys have been for consultations. They've seen the orthodontist has said that they need to have their teeth extracted. They found out about mewing, and they are swallowing and pressing their tongue in their palate to try and develop their maxillas themselves because they don't agree with the treatment that's been recommended for them. You will see there's millions of views on these. There's a lot of information out there on the impact that breathing, swallowing, and all that has had on the shape of your face. I've got a few of the videos on there just showing you what these kids are doing. They are desperate to sort themselves out. Also, TMJ problems. Do yourself a favor and look how many patients has got problems with TMJ and people trying to sort their own problems out because the dentist has got no clue on what to do for these patients. So, this is what you need to look for. You need to look for a patient like this that's in the mixed dentition. You need to have some baby teeth in there. You can see this is a deep bite, an open bite, crowding, wear on the teeth. Any of these cases will work. You need to be able to take some good photographs. For the time being, do your best. If you have to use your phone, take the photos. I'm going to show you how to take photos. I've got a really nice camera which I will bring to the course with me. The best investment that you can make with your money is to get a good camera that takes consistently good photos. Those photos you're going to be taking is going to help you sell your cases later on. It's going to help you build up a portfolio of your cases. And later on, I mean, there is not a case that I do not have an example of, just because I've been taking 100 photos a day for the last 9 years. So whenever a patient comes in with a crossbite, an impacted tooth, I can go back and show them before and afters, and that is a tremendously helpful thing to help you sell your cases. So you have to get a good camera that takes consistent photos. I will show you exactly the settings on the camera. I'll show you what lens to get. I'll show you what flash you need to buy. That is going to pay for itself in the first week. So find a case. I've said they're family members. The patient has to be in the mixed dentition. A patient in the permanent dentition is too late. That is course 2. Course 2, I can help you with that. So this is what you need to get. You need to get a 000 lab sheet. Put your name in, patient name, age, fill that in. You need to take an impression, 2 alginate impressions, upper and lower alginates. You need to take a wax bite. You need to take your photos, front, side, front, occlusal. You need your mirrors and your cheek retractors. Again, do your best with what you've got at this point in time. I'm going to go through this. We'll get you to get some really good photos. You have to have a lateral Ceph X-ray, and you have to have an OPG. The lateral Ceph is going to show us the skeletal balance of the face, and they're going to do the BIMLR elite tracing on that. So you cannot do the treatment unless you have a CEF. So if you don't have a X-ray machine that can take CEFs, you'll have to refer them to somewhere where they can take it for you. I do not start a case without a CEF. You need to have an OPG. The OPG will show you where the canines are. It will show you if there's any missing permanent teeth. Very important OPG. So once you've done those 2 X-rays and a set of alginates, you're set. You're ready. So you send this off to OOO, and you're going to get this back. You'll get the Schwartz Korkhaus analysis back. You'll get treatment suggestions. You've got your analysis there. You're going to have your set of study models. You're going to have your BIMLR elite that I'm going to help you and analyze. And we're going to go through the model analysis, the skeletal analysis, and we're going to come up with a treatment plan. So you have to bring this with you to the course. The more cases you bring with you, the better. And get those patients, get them started, because I can guarantee you, you will definitely be able to treat these patients. I've mentioned before, it is physically impossible to harm your patients with what we're doing. We're working with nature. We're trying to put balance back in the face. We're doing what nature is intended to do. We're putting growth back on track. Worst case scenario, if you get stuck, if you get confused, if you don't know what to do, take the appliance away from the patient for a month, let them function, take new photos, take new models, send it to the lab, and we will all help you get back on track. You cannot mess this up. It is physically impossible. The worst thing that can happen to orthodontic patients is they can lose their brace. And once they've lost the brace, you make a new one and charge them again for it. As simple as that. So please do not be worried about this. You've got a massive backup. OOO is right on the other line. There's Robert, Rod. When I started out with this, I found them very regularly, and they were absolutely fantastic in holding my hand through each and every case. I am pretty sure that we can make a blog, and we can make WhatsApp groups, whatever is necessary, where if you have any questions, any small things, and we mentioned having regular webinars and stuff to take you through the step, by the way, because one thing I want to say to you is you are not going to be alone. If you're going to be, like I said, if you're going to be placing implants, you can screw an implant in somebody's sinus and you can have a big disaster. With this, what we're doing, you physically cannot do that. It's impossible. So you should really not worry. I would just say my advice to each one of you is just get started and get your first cases. All right, thank you very much, guys. That's about what I want to show. I'll answer some questions if there's anything.
Yes, Stefan.
I hope you guys are excited about it.
Stefan, thank you so much about that. I mean, this is I approached Stefan about, must be well over a year now, Stefan.
Yeah.
To get the ball rolling with this. You know, I was quite lucky. About 26 years ago, in my VT year, I was exposed to orthopedic orthodontics, and I just thought that was the way it was done. It was only years after, when I moved practice, I realized that hardly anyone did it this way. So for me, it's quite strange then to have to go back and relearn how people do it traditionally with orthodontics, mainly looking at teeth and not even considering the skeletal imbalance. So thank you so much, Stefan. Certainly, and I've been working with you for this for a while, and you've put in so many, probably weeks worth of work just getting this, the lecture together, and I can't wait for you to present it. We do have quite a few questions, so I'll just go through them all in no particular order. It's just as I received them. It looks complicated, Stefan. How easy is it really?
It's literally, like I said before, it's about the technical skill, the skill with your hands is about as simple as difficult as doing a composite filling. So each one of you should be able to bend the wires. You should be able to adjust the appliances. Literally, if you're able to take an alginate impression, you can do the treatment. That is the skill level involved. The skill involved with this treatment is being able to identify what's the issue. It's being able to put the treatment plan together. And a lot of it, one of the tricky things is the management of the patients. And I am going to help you from mistakes that I've made in my practice. I'm going to help you avoid those mistakes. For instance, when I started with this, my first few patients, I said to them, listen, wear the appliance as much as you can. That's the worst thing you can say to any patient, because they're going to end up wearing it for 5 minutes a day. So what I'm doing now, I'm gluing the appliances in for the first 2 weeks. Doesn't matter how big they are, I glue them in. The parents come back and ask me, they beg me to do it again, because it means they don't have to nag their children. It takes your mind off it. The kids don't have to worry about taking it in and out and cleaning it. Yes, they come back after 2 weeks and they're all manky and gross, but you're not going to get a cavity in your tooth after 2 weeks. So then I make the brace removable. And the thing is, by then, those patients are so used to wearing that brace, they don't want to take it out. I mean, I get it, where the kids are sitting in the chair, I take the brace away and I clean it for them in the sink behind them. They actually sit up in the chair, they turn around and says, can I please have my brace back? Because they feel naked without it. So that's the kind of thing. So what I'm trying to say is that it's the management of these patients. You are going to have breakages. You are going to have people losing their braces. And again, what I'm going to talk to you about is that you have to have a proper contract in place where if the patients keep losing their braces, the parents will have to pay for it. You need to put that in the beginning of your treatment. Because if the patients keep losing their braces and they don't care about it, and you keep making them new braces for free, very soon you're going to start resenting yourself. So, but if you've got it in the contract and they've signed for it and they know that if they lose the brace, they're going to pay for it, they will look after it. And then if they do lose the brace, they're going to pay for it, which means you're not going to be out of pocket. That's the kind of things that actually is the hard bit about the treatment. Simple things like that. And I am going to show you all the tricks, the things that we've learned. I'm going to show you and make you not have that trouble, because I've been there. I've been there where I've made brace after brace after brace for kids. I kept on losing it. I didn't charge them because I felt guilty and all sorts of nonsense. You don't have to go through
okay. That was the great tip about sticking the appliance in for the first 2 weeks. All my daughters have been treated orthopedically. My youngest daughter has an upper 3D shorts in at the moment, except every time I go down for breakfast in the morning, it's on the breakfast bar. So as soon as I can get back into my practice, that's the first thing I'll be doing. Yeah. What about, you've answered this, but again, it's just come up in, complications of treatment. Can we get into trouble with this?
Obviously, I try to see my patients every 4 weeks to make sure that you adjust the braces. The only thing that can really go wrong is when the patient loses their appliance, and that's not a disaster. You just, make a new one. The kind of complications you will get is things like wires rubbing. Easy to fix. You just bend them out of the way. There is going to be a few adjustments you need to make the patients comfortable. But you can't screw it up, because these appliances, every time you turn it, they expand by 0.25 of a millimeter. So you're not all of a sudden going to have a massive stretch that's out of control, for instance. Everything happens really slowly. So if something is starting to go off the rails, which it hardly ever does, you will be able to catch it. But it is important that you see your patients regularly and just keep a track of it. Worst case scenario, if you, like I said before, if you lose track of a case, you can just take everything away, let them function a little bit, and start again. It's not a problem.
Okay, thanks. The other one I have here is, a couple of people have asked this actually in various formats. So, what if I can't do the fixed appliance part of the treatment? Does it stop me from doing the development part?
I certainly don't think it should stop you, because like I said, that everything you're going to do, because look what we're doing. We are making room for all the adult teeth. Is that good or bad? You're making the upper jaw wider to give the patient a wider smile. Good or bad? You're fixing a tongue thrust that can ruin their teeth for the rest of their life. You're getting rid of the tongue thrust, good or bad. When a patient is a developing class 3, you're developing that upper jaw as far forward as you can. It's all good. So even if you are not able to finish the cases with the fixed braces, you are doing your patient a favor. One thing, though, that I would say is that a mistake that I've made when I did course 1, I left there and I wasn't really sure about, do you have to finish them with fixed wire or not? I missed it during the lecture. And I said to 1 or 2 of my first patients, I said to them, listen, if we do this treatment really well, you're going to end up with perfectly straight teeth. You can't say that. Because this treatment is not aimed at getting your teeth perfectly straight. It's aimed at developing the arches. It's aimed at getting you enough space for the teeth. It's about getting the lower jaw in the right place. But when teeth come through, when they erupt and they are rotated, they rotated. And the only way to fix teeth that's rotated or angulation problems, that you need to fix with a fixed wire. So yes, you can do this development treatment and it's going to benefit your patient, but be aware, you cannot say to the patients that if you do this treatment, you can end up with straight teeth, because you can't say that. Does that make sense?
Yep, that's great. Thanks for that. Somebody asked, now, as a GP, are we allowed to do orthodontic treatment on children below the age of 16?
No, definitely.
Yeah, I can confirm that. That's not an issue. I've been doing that literally since I was in my VT year. So.
I mean, you saw that kid that I treat 3-year-olds.
Yeah.
And the sooner you pick these problems up, the better. I had an issue when I started this 9 years ago. When I started treating the patients, a lot of patients started coming to our practice and not going to the local orthodontist, and he obviously didn't like that. So he wrote a letter to me saying that I wasn't allowed to take x-rays on patients under the age of 10. He decided that I am not allowed to take x-rays because I'm not allowed to take it. Anyway, I did write a very long letter to him explaining to him about skeletal imbalances. I never heard from him again. So you'll get nonsense like that, but no.
Okay. Yeah, no, I don't think that's an issue really. And as you said, we're not really doing anything wrong. There's nothing really that we're going to do that's going to cause problems here. No. What is the difference between a skeletal problem and a dental problem, and where's the borderline? That was somebody that mentioned this earlier. Yeah.
Well, there's sort of 3 elements, I would say, really. A skeletal problem is something that you see on the Bimler elite tracing. Is when you look at somebody's face from the side on, where your lower jaw is, if it's too far forward, your lower jaw, it's a class 3. That's a skeletal problem. That's your lower jaw developing too much. You also can have a skeletal problem where your upper jaw is set back too much. That's a skeletal problem. So a skeletal problem, I think by definition, you can say that it is an imbalance in the size of the upper and the lower jaw, where they're not in the correct balance. You need balance in your face. Another issue, the second issue, is the arches, the dental arches. You can have narrow arches where the arches of your teeth hasn't developed properly, and that's mainly because of your tongue not being in the right position, thumb sucking, cheek habits. And then the third thing is the orthodontic problem will be teeth that's drifted in the arch, and teeth that's rotated, teeth that's, wrong angulations. And orthodontic treatment, or the moving of the teeth, you can only do that with a fixed wire. And you can only do that when you're in the permanent dentition. We never push on a deciduous tooth with a wire. So those fixed braces you see, you cannot fit them on deciduous teeth. The deciduous teeth hasn't got a periodontal ligament, and you cannot move them orthodontically. You only use them for anchorage to do the orthopedic treatment.
Right. What about breathing problems? Does this help with breathing problems?
Yeah, breathing problems can occur in a number of areas. One of the most common areas where you have breathing problem is with you have a narrow maxilla. When your upper jaw is really narrow, the bone in the vault of your palate sits in your nose. You can't breathe through your nose properly. Another area where you can have a breathing issue is at the pharyngeal tonsil area, which we normally see on the Bindner-Elite tracing as well. Now that, if you have a narrowing in the pharyngeal tonsil area, that gets a lot better when you actually develop the mandible forward. But developing, because what happens is if you look at somebody's palate, if you have a narrow maxilla, that vault of the maxilla is in your nose. When you develop that maxilla in width, that palate comes down. And this happens. And as that bone comes out of your maxilla, you can breathe through your nose a lot better. It makes a big difference. And also, as you know, with snoring, when you sleep and your lower jaw falls back, that makes you snore and get sleep apnea and all that. Everything that we do is designed about getting the lower jaw down and forward, obviously excepting class 3 cases.
Couple more here. What about, is there a link between breastfeeding or lack of breastfeeding and development of the maxilla?
Absolutely. I've got a whole section on that. All the research there. The key thing for feeding children is that they have to be upright. When you put your child back, if you lie back, you can try this yourself. If you lie in your bed with your head back on the cushion, you put water in your mouth, you choke, you aspirate. And to stop you from aspirating, you then swallow with your tongue forward, and that is how babies start developing a anterior tongue thrust swallowing habit, is when you are fed lying back. So children has to be fed upright, and then the shape of the nipple and the way, the softness of it, it all plays a part in your jaws developing correctly. So you have to be upright. Bottles and dummies, big issue. Again, there's nothing better to fix a thumb sucking habit than a Schwarz appliance, because having your thumb in your palate is that comforting sensation you get. And when you have the Schwarz appliance in there, it takes that away immediately. And kids stop sucking their thumb the same day that you fit that appliance. Then again, that's one of the appliances that I glue in.
Okay. So I'm just reading through the questions here. Alginate impressions, not PVS?
Definitely, with just alginate.
Yeah, it's fine. Yeah. Susie's mentioned about having no patience. Susie, you're not working at the moment? I woke you up there. Yeah, one thing I found actually, maybe I can answer that one, is I've had several online consultations. I've had lots of people that were due to see me, and the one thing that I think going back is I'll be starting the ortho cases first, because I think despite economic issues, parents tend to treat their children first. So I think irrespective of what's happening now economically, I know I'm going to have a lot of ortho cases on children ready to start. So that's sort of an easy one. So no patients now doesn't mean no patients when you necessarily get back. So maybe
I guess when we start, because I know the Guernsey Dental Association has a big thing about causing spray and aerosol and stuff, you know. When you do the impressions, you're not, at least not going to make an aerosol. God knows what's going to happen with this. But so I cannot stress enough how important it is to get your patients. You have to go back with patients booked in already. No question about it. Otherwise, you're not going to do it. I'm sure all of us has been to a course where you learned to do something and you went back. You said, "I'll book one in later on," and you just never did it. So that's why it's very important to follow. And I'm pretty sure, because I remember when I did course 1, I sat there and I could see the faces of my patients come up. I said, that is that patient. I actually wrote the names down because, you have them already.
Yeah. Catherine's asked about charges for treatment, and I know that'll vary quite significantly throughout the country, but charging for Schwarz type of treatments?
I charge for the orthopedic treatment differently from what I charge for the orthodontic treatment. So we've got our charges in 2 phases. So phase 1, when you do the arch development and the reposition of the mandible, we charge one way, and then for the fixed braces, we charge another way. So the first way we charge is we charge a starting fee. Now that starting fee includes the first 2 appliances that you have. So normally it's a 3D Schwartz appliance in the upper and a Williams in the lower, for instance. Those 2 appliances, our starting fee at our practice is £1,500. That the 2 appliances together will be about £300, £350. I'm sure, I don't know. That's roughly what they are. So you're more than covered for the appliances in the beginning. And then what we do is we charge a monthly adjustment fee. So the patients put a deposit of £1,500 down, and then we charge £125 a month. The reason we do that is because some kids need 2 millimeters development, and some kids needs 15 millimeters development. So you can't really charge everybody the same. And I explained this to them in the beginning. I said to them, listen, if you have a severe problem, obviously it's going to take longer, because when you turn the screws, the brace expands a certain amount. So a kid who needs 15 millimeters of development, they will need 16 months of treatment. A child who needs 3 millimeters will be 4 or 5 months. So that's why we charge them. Now, you start with a £1,500 deposit, and that includes your first 2 appliances. Then it's £125 a month for as long as it takes to develop the arches. And then in the contract, we've got it that when they need a bionator, the bionator will cost them £350 to pay for the appliance. And then the £125 carries on. That normally carries on for 6 months. So, yeah, that first phase of treatment will be about £3,500. Yeah, it is what it is, and I tell you what, the parents do not have an issue with that.
I think this is something we'll certainly cover in detail on the
course,
how to set your fees. Nick mentioned, I take it we're finishing with straight wire, not round wire.
Sorry?
We're finishing with straight wire, not round wire.
The straight wire technique that we use is the Delta Force bracket system. The Delta Force brackets are unique. They're they're a triangular shape, and we use thermal arch wires. Now the arch wires, you cool them down and then they become soft, and it means that you can start with a square wire from the beginning. So you don't have to start in a round wire, you start in a square wire, and you're actually torquing the teeth from day one. So we normally start with a square wire. It's a 20-20 thermal square wire that we start with, and then we level and align the teeth, and then you later on go to a rectangular wire, and depending on the division of the front teeth, you can then move up to a 019 by 025 wire, and then you can go into stainless steel wire to do sliding mechanics. So you can work your way through the different arches. The only time really when I use a round wire is in a skeletal class 3 patient in the lower jaw. Now, the reason why you have a round wire is because you do not want to torque the lower teeth forward. So the thing is that this is your upper jaw and there's your lower jaw. If this lower jaw is overtaking the upper jaw, you've developed this upper jaw as far forward as you can. The last thing you want is to bring this lower teeth up, because that's going to bring the lower jaw forward. So that's why when we treat the skeletal class 3 patient, we stay in a round wire in the lower. That's really the only time I use a round wire. I hope that answers your question.
And a few people have asked various versions of this. So basically, if you can't do fixed treatment, are we going to be running courses? Well, I think that's pretty much your
course 2.
Course number 2.
Yeah.
Right, so course number 2, which Stefan's, now he's got time on his hands.
Actually, I'll show you, look, this is my surgery, and there's my photos I've been taking. Look at the mess I've made. So here's my camera. I spent all day today with my camera, and I've got this phantom head. because obviously I don't have any patients, and I've been making different ligations and showing how to do this. I'm actually busy doing it as we speak. I'm nearly finished with it now.
Hope that answers your question. So yes, definitely. And also for those of you who haven't or are a bit apprehensive about, you know, fitting a fixed appliance, I mean, this is something that we at the lab have been doing for, well, 30 odd years. You know, we have indirect bonding trays. Those of you who've done CFast, you know that system already. But we can now have the brackets positioned for you perfectly, and then it's just a case of sequencing. But what you'll probably realize once you've developed the arches, the straight wire bit's actually relatively simple, because the jaws are in the right, you know, jaws in a good shape, a good position. So that bit of it really simplifies the fixed part by developing the jaws in the first place.
Yeah,
But,
and obviously you're later on going to start patients that's 25 years old and that has the lower jaw back. So you will combine the treatment. So we do combine the straight wire and what we're doing in course 1. It's just something that you will learn how to do.
Guys, I think that's it. Stefan, thank you so much for that. It's just every time we talk about this, I get excited all over again. Really looking forward to the course. I don't know if we've got a date or not yet, but certainly we'll get dates out to you, and we will do this course over a couple of days. We'll get to know each other a lot better, and you know, you will never ever look at children the same way again in terms of their teeth. You will never look at teeth. You know, you start to look at jaws. It's life changing. It has been for all my children. You know, I would never dream of doing this any other way. So, Stefan, really looking forward to meeting you. Those of you who couldn't hear or whatever, I will get this recording out to you all. Okay, and any questions, please email me or email Gary or Stefan.
Yeah, Bijou, Stefan, thank you very much for tonight. Guys, as I said at the start, please get in touch with any questions. As I promised, we will make a final decision on the course, whether it will go ahead or not, on the 30th of April. So fingers crossed we get some good news and there's a little bit of a relaxation in the lockdown. But if not, the next dates will be the 17th and 18th of July. So please check if you're all free. That the course will be at the same venue. We've checked. We've got the room booked for that date as a backup. So enjoy. I will ensure that the recording gets out to you. It'll take a little bit of while to upload and get a link to send. But as I said, it's been lovely to meet you all. Any questions, get in touch at any time. Thank you.
Thank you very much, guys.
Thanks, Stefan. Good night.
Thank you. Bye.
Thank you. Bye.
Bye, everyone.
Thanks, everyone.